following podcast is part of a certified educational activity titled RSV Primary Care at the Center of RSV Prevention, Community-Focused Strategies to Focus Trust and Vaccine Acceptance. Access the entire activity and complete the post-test at peerview.com/DEN860. Downloadable slides and practice aids are also available.
Welcome to this presentation entitled Primary Care at the Center of RSV Prevention, Community-Focused Strategies to Foster Trust and Vaccine Acceptance. My name is Chuck Vega. I'm a clinical professor of family medicine here at the University of California, Irvine, where I also serve as assistant dean in our School of Medicine. I'm delighted to be joined today by Dr. Brenda Tessini. She is an associate professor of medicine and pediatrics at the University of Rochester. She's an infectious disease specialist there with a focus on the prevention of respiratory infections. So, Brenda, it's great to have you here today. Thank you for joining us.
Thanks, Chuck. Wonderful to be here.
So let's discuss our goals for today. We are going to equip you with strategies for identifying adult candidates for RSV vaccination. The guidelines have changed, and it's important to understand. We have, I think, more direct guidelines that will help us to get the vaccine on board, because we're going to be talking about who has received the RSV vaccine since it has been available now for a couple of years, and who do we still have to reach. We're going to be talking about how different evidence supporting the vaccine, its benefits, its potential adverse events, and helping to put that into context for patients. And then we'll be talking about how to actually apply this data to the clinical practice to make sure that we are vaccinating those who really need it and promoting better public health overall. I work in the biggest safety net clinic here in Orange County, California, and that's what I spend a lot of time doing. During the fall time, I feel like I'm at least a half-time vaccine counselor and half-time physician, because that's how much time I'm spending discussing vaccines with patients. Because we always have to be suspicious. We always want to keep these infections at the fore of our minds. Certainly when we see somebody with upper respiratory infections, it's very hard to tell the symptomatology of RSV versus COVID versus flu apart in an adult. But I think the key to all of these different infections is they're very preventable, and particularly severe infections are quite preventable. And so we'll be digging into that today and hopefully giving you some tools to better protect your patients and community. So we're going to use some cases to frame up this discussion. And first is Linda. She's 61 years of age. She has chronic obstructive pulmonary disease, COPD, and asthma. And her chief concern is that I've been feeling more short of breath, and I'm using my inhalers, but I still have this difficulty with breathing. That's concerning, and it opens up a host of potential issues. But which we will get into that history if you're seeing a patient. We want to focus a little bit on her vaccine history. So she does have custody of her two young grandchildren. They're ages 1 and 5. Remember, a lot of infections, including RSV, are passed from younger children, school age children, on to older adults. And she did receive the flu and COVID-19 vaccines. It's good to know she's protected against severe illness with those infections, particularly with her history of COPD. That's important. So I was taught in medical school that RSV is really a disease of children. It's an infection that is most pertinent among the pediatric population. And I certainly rounded in our children's hospital during the wintertime. And yes, it was just full of RSV. And so that was really my mindset going into training and residency. But while RSV is an important disease in childhood, and certainly there are many, hundreds of thousands of children who become infected with RSV every year, it's actually among older adults who bear the greater impact in terms of morbidity, serious morbidity, things like ICU admission, intubation, and mortality as well. And just like in Linda's case, many times this affects whole families because RSV has a fairly high attack rate. So while we see the majority of illness that's harbored in this cohort of young children, school age children, it's actually the greater impact in terms of morbidity and mortality. It's the older group, particularly children, though, under 1 year of age, are at high risk for complications of RSV as well. And so when we look nationally in the United States at folks 65 and above, you can see there could be up to 160,000 hospitalizations per year and up to 10,000 deaths per year due to RSV. And we got used to in the COVID, years, the lockdown years to 2021, 2022, there really weren't many cases of RSV because of social distancing and isolation and putting and making sure that we were really trying to minimize all respiratory viral illness during the crisis period of the COVID-19 pandemic. And so RSV kind of went away, went out of our minds a little bit, but now it is back and it does follow the seasonal pattern. And it seems like we have a seasonal pattern now where RSV will appear a little bit later in the cold and flu season versus influenza, generally speaking. But we see these peaks during the winter time, and they're similar to what we've seen in previous years. Every year is a little bit different, but now we have COVID-19 in that same mix as well. So we do want to be aware of it. And we do wanna be aware that, vaccination is really the key way to, protect individuals against RSV, as well as if you wanna look at from a public health perspective, protect society from some of those consequences of RSV. Those thousands and thousands of hospitalizations, thousands of deaths as well. And because we don't really have great therapeutics right now for folks with RSV, unlike we have for SARS-CoV-2 for influenza, we have antiviral agents that can offer particularly help for folks at the highest risk of complications. We don't have that for RSV, so it really comes down to vaccination. How are we doing with vaccinations? Not that great in terms of uptake. So if we look at the group that really needs it, and Brenda's going to go over the indications for RSV vaccination among adults in just a second, you can see that there's really kind of a lag, and we're still under 50% in terms of trying to get that vaccine on board for those who need it most, 75 years and over. We're going to spend some time now kind of going into the why behind that, and also, is it worth it? Is the vaccine actually effective? And what are some of the drawbacks of the vaccine as well? And with that, I'm going to hand it over to Brenda now.
Thanks, Chuck. And really can't overstate how exciting it is to have a vaccine for an infection that causes so much morbidity and death in vulnerable patients at the extremes of age. It's really remarkable. And you all may recall that the initial recommendations for RSV vaccination involved a difficult topic that I think we'll continue to get into today, using shared clinical decision making as the first recommendation, and I think that is part of what contributed to the slow uptake of vaccine um, in the older adult population. And so when the ACIP met in June of last year, they took a lot of feedback from frontline providers and pharmacists, those trying to administer the vaccine, as to how that was working for them, and found out that it wasn't working very well. And coupling that with an accumulation of data as to who really is most at risk for severe RSV infection, they adjusted the vaccine recommendations to be a universal recommendation for all adults 75 and older, and a recommendation for adults 60 to 74 who have various conditions that we've studied and found to know place people at higher risk of severe RSV disease. So that's disease that requires you to go to the doctors, hospitalization, ICU admissions, and death. And so it really kind of pulled out that decision making and laid it out for us. So we're going to go through that in some more detail. So again, just to reiterate, that the initial recommendation involving the shared clinical decision making was to balance benefit and risk of vaccination as we were getting more and more data about both the safety and efficacy of these vaccines, And a major thing was to balance any early signals of potential adverse events or reactions to the vaccine with the targeting the patient populations who are most at risk to have severe disease, to be hospitalized, and to potentially even die from RSV infection. But as we all know, that was not easy to implement. There are time constraints and understanding constraints, particularly as a lot of vaccination occurs via standing orders in a clinic or even at a pharmacy where it's not the patient's actual clinician who is trying to have this conversation with the patient and administer the vaccine.
Brenda, I would like to attempt the impossible and actually defend shared clinical decision making for a second because I think it's gotten a bum rap. Yeah, because I'm doing this, right? And I I mean, I used to practice more of a presumptive model of vaccination, in which your case would be like, well, we're going to increase your metformin today, and please make sure you get your labs before your next visit in 3 months, and we'll give you the RSV vaccine today, and also, oh yeah, that's right, we'll increase your valsartan too, or whatever. And so it would just kind of be like, oh, we're just going to do this, right? And around 2021, I realized that would get me punched or stabbed. And so I stopped doing that after a few, not one, but several episodes where I was like, "Oh, this is different." Became a different environment, because of the politics and the all the controversy around vaccination, which I think still continues to this day. But that said, so what I do is instead I do give and take with patients and talk about their concerns, and I think that that still has to be a part of it. But I understand as a public health message, shared clinical decision making, providers might want something that's a little bit more firm saying, no, you really should get this vaccine. You're 76 years old, you're 62, but you have diabetes and asthma, say, or what have you. I know you're going for the risk factors in a second, but yeah, there's always some element in shared clinical decision making in pretty much every decision I make with my patients. So in of itself, it's not a terrible thing. It's an enlist patients. It's greater for the provider patient bond, and there's a form of trust that builds through that decision making process together. But I understand it, in terms of messaging for a country, may not work as well.
Yeah, I completely agree, Chuck, and that's a great point to bring up with any individual patient, and particularly when you are their clinician who knows them and are taking care of all of their healthcare needs. Having that discussion about why this is beneficial for them and why you're making that recommendation and hearing their concerns and being able to address them is critical for the RSV vaccine and everything else. Every other decision that we make with our patients for sure. But yeah, they found, and we found at the kind of health policy level, it was really difficult to not be able to arm clinicians and those providing vaccines with some more hardcore evidence and recommendation as to who is at the highest risk and what do you bring to the table when you have that conversation to make the decision with your patient about if and when to get vaccinated for RSV. So yeah, it's really bringing that back down to the patient level rather than at a policy level, so we all have the information we need to help our patients make an informed decision about vaccination. And so here, getting into the weeds of that 60 to 74-year-old recommendation, here's a comprehensive list of the various types of conditions and then some specific conditions within those that place patients in that age group at much higher risk of having severe RSV infection. And you'll see quite a few common conditions that multiple may likely be present in your patient, as Chuck was mentioning. A lot of the patients that we care for have chronic lung disease, diabetes with already evidence of some end organ damage, severe obesity, cardiovascular disease, and an important population that we'll get into a little bit more specifically are people who live in a nursing home or other long term care facility, including assisted living facilities. And there is still another category, again, of really continuing that tradition of making a decision together with your patient as to uh, if they will benefit from the RSV vaccine is if you and your patient decide together that they do have other chronic medical conditions and risk factors that would put them at risk of severe disease from RSV or other respiratory infections. And this highlights how many patients in this age group, and we'll look at the 60 and older age group who do have at least one of the conditions listed to place them at risk for severe disease from RSV. And there's some variation by race and ethnicity, but you can see that the majority of people in that age group have at least one of these conditions. And this is where we'd like to highlight the long-term care facility residents and really appreciate how much higher risk they are of getting RSV to begin with because of the communal living scenario. And if they have infection, are so much higher risk of being hospitalized and dying within the hospital if they get RSV infection. So this is a huge group to target. um, this here is specifically nursing home patients, but we found very similar data for patients who live in assisted living facilities who may still be cared for by community primary care providers. So, really important to target those patients. And here you see um, the relative risk of infection and hospitalization, nearly 7 times more likely to be hospitalized, and the numbers are small, but nearly 20 times more likely to die from RSV than similar age patients who live in the community. So very vulnerable group to target with vaccine. And how likely are your older adults to want to be vaccinated, accept vaccination? And Chuck, please chime in here too. But the data would show that, over time, and this is another way to see data that we saw earlier. These older adults are getting vaccinated. That has kind of plateaued this year, and we hope to see that rise again as we start up the next respiratory virus season in the late summer fall this year. But there is still a significant group of patients who plan on getting the vaccine or probably will get the vaccine. And those are patients it's great to have that conversation with and see where they're at with wanting to get vaccinated. And there is still this ongoing group of patients, 20-25% of patients who probably or for sure do not anticipate to get the vaccine. So that's some higher hanging fruit. But I think it's important to focus on the fact that the majority of people in this age group, have got the vaccine or likely will get it with some encouragement and conversation with their provider. So let's come back now to our patient Linda, who's 61, has chronic lung disease, about COPD and asthma, and is coming in with signs that is, struggling with her breathing, is lives with young children, has already received influenza and COVID-19 vaccines. So Chuck, how would you approach Linda? Is she indicated to get the RSV vaccine?
Right. So 61, so she's over 60. So she doesn't mean it by age alone, but having the presence of either COPD or asthma. And, we can certainly have both diseases simultaneously. And so, yeah, she is definitely somebody we would target for an RSV vaccine. Now, again, her chief concern is important to me, and I am worried about it. I will ask about any symptoms of upper respiratory infection. I don't think her having a upper respiratory infection not otherwise specified would preclude me from giving the RSV vaccine today. I would hope it's not RSV, but there's also a lot of other reasons: inhaler technique and adherence and exposure. So we'd have to get into that as well. But I was thinking about your list of that long list of different chronic illnesses, chronic conditions that predispose folks to complications of RSV, and that's why we do the RSV vaccine, is to prevent the complications. Like all respiratory vaccines, again, Brenda, this is your area of expertise, so please correct me if I'm wrong. That they're most effective at preventing the worst kinds of cases, the cases that put folks in the ICU and the potential mortality. So that's where they're going to have the most benefit in terms of your garden variety RSV. Just getting the infection from your 1 and 5 year old, it's not as effective. And I think you're going to go over a lot of data looking at lower respiratory tract disease associated with RSV. But on that list that I want to just call out real fast is that if you have major dysfunction chronically of any organ, that's a major organ, right? Your brain, your heart, your lungs, your kidney, your liver. Really, you should think about vaccinating, because those are the folks, they have these significant predisposing conditions, including out when I talk about brain. I have a lot of patients now who are living many years, healthy years into their 60s with diagnoses such as cerebral palsy or other severe motor conditions. Those folks would be in the group as well. And I see under vaccination
Yeah.
across the board for those individuals during adulthood.
Yeah, that's a great group to highlight, Chuck, with patients with neuromuscular conditions, which
Mhm.
affect, both the full nervous system, including the control of the respiratory tract and protection of the airways. So yeah, very, very high risk group. Wonderful, wonderful group to bring up. And we found also to highlight, patients who have other organ disease, not primary respiratory. When patients do get hospitalized with RSV and other respiratory viral infections, we find that there are kind of different groups or categories of patients, those that are there primarily because of the respiratory issues and need that extra respiratory support, but also patients where having this infection now has set off and
Right.
exacerbated another underlying condition. And so I think that's really not appreciated often in the general public, and can be a great discussion point with patients. That's a huge group that we see coming to the hospital. And you're right, we'd all love to never have a cold again and not be in bed sick for a couple days or a few days. But the real goal of these vaccines are to keep people out of the hospital, and to prevent death, keep them out of the ICU, keep them off ventilators. So that's really what we're trying to target with these. And it sounds like for Linda, the question may be more, when, that
Mhm.
decision making with her might be more of the when to get it rather than the if.
Yeah, that's a really good point. And I just wanted to really thank you for focusing on long-term care facilities, because it wasn't that long ago. You just have to think back to 2020 and the horrible things that were happening in long-term care facilities around the country with COVID, to see just that. I think that was really where we felt like viscerally the impact, which was a real tragedy of these infections. So definitely that is the group to protect with every vaccine that's possible.
Yeah, yeah, for sure. I think we collectively, as an entire medical community, really need to support long-term care residents and the staff who care for them. So we do want to always protect all of our patients, and particularly those most at risk for severe disease. And so now we'd like to make sure that you're all aware of the recent advances in vaccination, up to date data on both the efficacy and safety of the RSV vaccines. And to kick this off, let's meet Brent. He is 66, has type 2 diabetes with some mild renal impairment, GFR around 70, and he's here today for his annual flu shot and to get his COVID booster. Wonderful. Um, you recommend that he receive the RSV vaccine today in addition to the flu and COVID. But he's not as interested in doing all three. He's worried about how you might feel after getting three vaccines on the same day. And so, what are the current RSV vaccines? We have three available. Two are made from a protein subunit, which is kind of the old school vaccine type. And what's important to know for all of the vaccines, and what was really a huge breakthrough to be able to finally have effective RSV vaccines, is that they use this special conformation of the protein, the important protein to use. So it's a pre-fusion F protein that is the protein that generates a protective immune response to RSV. So they were able to stabilize that, which took decades of research to come up with this. And now we're seeing, this explosion in the ability to protect against RSV. So we have two of the protein subunit type vaccines. They, of course, being vaccines, have difficult to say names. So we do have trade names here to help everyone keep them straight. There's RSV pre-F3, known as Arexvy, RSV pre-F, known as Abrisvo. And then we also have the newer kid on the block, an mRNA-based vaccine, which I think we're pretty familiar with from the COVID vaccines, that type of vaccine, called mResvia. And so we'll talk about all three of these in terms of their efficacy and some safety data. So we'll start with the RSV pre-F3, Arexvy. And for all of these, there are slightly different endpoints and slightly different ways the studies were designed, being clinical trials. And so this study looked at RSV associated disease at all, as well as medically attended RSV associated disease. And this is of the lower respiratory tract. So, based on a list of signs and symptoms that would indicate a lower respiratory infection. And again, as we talked about earlier, what we really care about are hospitalizations and more severe disease, but even looking at just medically attended. Like, you went to your PCP, went to urgent care to get this checked out. It was almost 90% effective at preventing that disease. I mean, just amazing. And this was conducted around the world, almost 25,000 patients. And so when you combine a couple seasons of data, and these studies were all conducted during that period Chuck was talking about, where we saw very little respiratory infectious disease at all. So really kudos to the teams for getting this work out there in the height of the COVID pandemic. And so when you combine 2 seasons worth of data, you get again at the, almost 80% effective at preventing disease that you would seek any kind of medical care for. It's incredible, really incredible. And similar results for the RSV pre-F vaccine, known as Abrisvo. Again, so around 85% effectiveness at preventing medically attended, seeking medical care or lower respiratory tract infection, and really maintained that around 80% over the 2 seasons. And this is looking at even more patients, almost 37,000 patients, and again, across the globe. And turning to the mRNA-based vaccine, mResvia, this is a slightly different way to look at the vaccine effectiveness, but just looking at these two lines, you can tell there was barely any disease in the vaccinated cohort, about 1.5 infections per 1,000 person years compared to almost 9 per 1,000 person years in the placebo. Incredibly effective after a year. So again, shakes out to about 85% effective.
Yeah, so I think this is I think is pretty tremendous. Maybe just to contextualize this a little bit, this is going to be more effective than our average influenza vaccine, and maybe you could put
Oh
it
yeah.
even in terms of the SARS-CoV-2, like this relative efficacy. I know it's not obviously the same thing, and there's not really a head-to-head trial, nor should there be, but it seems like this is stronger efficacy, and that's why you're excited.
Yeah. Yeah. And these are absolutely amazing numbers to see, more than we would ever expect to see. I think the early results from the COVID vaccines got us a little
Oh
skewed
yeah.
as to understanding how effective and a vaccine is supposed to be and what the goal is. And again, the goal is not to prevent a cold. It's to prevent hospitalizations, but these are even highly effective at preventing a cold, like having any symptoms that you notice, and to be, 80 plus percent effective at preventing disease that you need to go to your doctor for, in a good flu season, 60% effective at preventing hospitalization is phenomenal. I mean, that's kind of our goal. Even 30, 40, 50% effective at preventing hospitalization, we're very happy with. So that's, yeah, a great context for it. These are incredibly impressive, powerful vaccines. And looking at it in the real world, which I think is always helpful, these are large, very large studies done. And the bottom group of studies was all vaccines together. So, just in general, how effective are these vaccines in the real world? And they maintain the effectiveness that we saw in the clinical trials, which again is quite impressive. And looking at hospitalization in particular, which again is what we care the most about, and we're in the high 70s, 80% effective at preventing hospitalization in large cohorts of older adults. So it's really, really holding out to be true. And to look at the other aspect, and we've talked about efficacy, what about the safety? That's everyone's other main concern. And as you're having these discussions with your patients and trying to determine if when they should get the RSV vaccine, this is obviously a top concern of both providers and patients. And Guillain-Barré syndrome was a potential adverse event that was coming out even in the early clinical trials, and so it's the one that's been watched most closely throughout the rollout of these vaccines. And in the fall, FDA presented some great updates to the safety data around this. And, it does look like there is some small association with increased cases of Guillain Barre syndrome in patients who had, at this point in time, there were only the two protein subunit vaccines, Arexvy and Abrysvo, available to study. And there was a very small signal that there may be increased number of cases compared to the baseline rate in this population. And it's been hard to know what is the baseline rate of Guillain-Barré syndrome in this population. But they've done some really great study designs to try and get at this. And they also looked at when the vaccine was co-administered with other vaccines, and 30 to 50% of them were. This kind of gets back to our case of Brent too, is does the safety profile change if you're also administering it with other vaccines? Because other vaccines have also been associated, that we use routinely, have also been associated with an increased signal of Guillain-Barré syndrome. And there was no evidence linking giving the vaccine with other vaccines that impacts the safety profile. So I find that these numbers a little hard to contextualize, of this kind of these attributable risk numbers, but I think we have some easier to digest numbers. But basically, um, what this is showing here is comparing patients to themselves in their non post vaccine period. They found that um, there were 24 cases after receiving a RSV vaccine out of over 2 million doses of patients versus 11 cases of Guillain-Barré in periods when that person had not received the vaccine. And similarly, 18 cases of Guillain-Barré out of over 1 million doses of the Abrysvo vaccine, and again, around 11 in a period when you haven't received the vaccine. So tiny, tiny numbers of cases compared to the doses of vaccine given. But again, to put it into context that at least I understand better, what we really care about is a risk benefit analysis ratio. And overall, RSV vaccine reduces hospitalization in this age group by 75%. And like, bottom line, remarkable. And the main risk that has had some signal coming out is again for the two protein subunit vaccines is this very small but and quite rare risk of Guillain-Barré syndrome after an RSV vaccination, and basically 10 extra cases of Guillain-Barré syndrome in this whole patient population per 1 million people vaccinated. And that's roughly on par with what we see with both the zoster vaccine and the flu vaccine. Those are also kind of single digit cases per million doses given in this population. So it's similar, maybe a tiny bit higher, but overall quite similar to both influenza and zoster vaccine, which we routinely give to this population. So putting those two things together, the benefit of RSV vaccine in this population, and this is, partly what kind of honed that latest ACIP recommendation, is the benefit in this group far outweighs the risk. So for 1 million people vaccinated, around 5,000 RSV hospitalizations are prevented, and 300 to 800 RSV deaths are prevented, and weighed against potential 10 extra cases of Guillain-Barré syndrome. So really remarkable numbers. And for me, that's what matters. And I think in talking with your patients, that's kind of what they care about is what's the balance here. And in conclusion, the ACIP putting this all together, acknowledge that there does seem to be some increased risk again in this age group, and it aligns with the early signals they were seeing. Very rare, less than 10 cases per million doses, and that there is no strong impact on administering vaccines together or separately on that risk. So let's get into the timing of giving the RSV vaccine. Again, as we've heard from our patient, getting more than one and certainly getting more than two vaccines at once is is a common concern topic with patients. And so when you're thinking about, trying to balance all of the things that you're doing together in your visit, the RSV vaccine really makes the most sense to give in the late summer, early fall. Again, before we know it's in most of the US, very seasonal infections. So right before the season, right? Give the vaccine, you're going to have your highest levels of immune response. And so, for most of us, that ends up being August to October. And it's important to kind of pay attention to your local RSV season that year when you're starting to see some cases. And with and the another question we get a lot is how often will someone need to get this again? And I don't know if that's come up for you yet, Chuck, but as of now, only one dose is recommended so far. Again, we're kind of getting into year 3 data to see how long the protection will last from these vaccines. So we may end up seeing recommendations in the future to redose. We're kind of expecting that, particularly in the older age population. The immune responses in general can wane. But for now, it's just one dose. So giving it at that time of year. So if you're looking to space out some vaccines, and you have an ongoing relationship, holding the RSV vaccine to give it in that late summer, early fall really makes the most sense.
Brenda, can I ask you a question on
Yes.
timing? I believe that they did research looking at, a second dose a year later, and it didn't
Mhm.
really seem to offer a lot of benefit to have that second dose 1 year after the first dose. Is that right?
Exactly. Yep. Yep. So for yeah, the various vaccines looked at that because they want to know too
Right, right.
when to give it
You need a
again.
test.
And yeah, it did not like boost the immune response at all. So there was no indication that it would help you to get it in that second season. So that we know for sure.
So
Um
I've actually used that to because there's a small subset of patients who are like, no, I really want this. I get all my vaccines. Can you just give me another one? Even then I look back at the record, like, oh, you had this like 9 months ago, and like I just want another one. It's like so I turn to those patients. Well, maybe that's not a great spend of your time to get that vaccine, but we haven't done colorectal cancer screening for a few years, so I'll use that momentum to try to get, or maybe it is the zoster vaccine or something else in preventive care can open up. But yeah, so because I have a feeling a lot of our audience might be getting a small minority of folks who really want that annual RSV vaccine, right? Really, that's not indicated right now.
yeah, exactly. I think that's a great pivot. And again, I think what sometimes works too to discuss with patients is that the viruses themselves, COVID and flu, change a lot. They mutate, they change, and that's why we're updating the vaccines and we need to kind of keep on that protection. But RSV does not mutate, change nearly as much. And again, we have the data to say that it's not going to help you. So let's save it. There's plenty of other things we can do today. And yeah, save it for another season. And again, harping on these, the timing and practical considerations, it can be given. And again, as we're talking with Brent, it can be given with any of the other vaccines. A lot of the latest ACIP meeting in the fall was looking at data around this. And there was, for a couple combinations of things, there was like a question based on how they looked at immunity. Could there be some signal of a slight decrease in immunity to one or the other in like very specific combinations? But it really didn't bear out across studies. And what they were looking at to determine immunity also isn't the best way to determine immunity. So the committee and practitioners in general really don't think that's any reason to not give them together if the patient is otherwise willing to accept that. The general tenet for vaccines is you got someone there willing and able, give them if you can while you have that patient in front of you. But this too is an area to have ongoing conversation and decision making with your patient and understand they come in, every 3 months for follow up of this, or they've gotten all of their flu vaccines and COVID vaccines so far. I have no reason to think they won't come back and get the RSV vaccine if they are hesitant to get too many at once. And again, additional counseling. So beyond the rare, very rare Guillain-Barré syndrome association, the most common adverse effects are what we see from every vaccine. It's the sore arm. tiredness, potential fever, and kind of those nonspecific malaise, transient flu-like symptoms. And again, for most of the studies, these were, besides the arm pain, also quite similar in the placebo group. Um, so if patients ask, it's really not that much different than any other vaccine they've gotten. And there are, of course, the reporting systems, as with all vaccines, to report any adverse events. So coming back to Brent, the 66-year-old with type 2 diabetes and mild renal impairment, who's already here to get his annual flu shot and COVID booster, but is worried about adding a third to that mix. So how would you approach this, Chuck?
Well, I agree with your general sentiment that it's better just to try to get more vaccines on board now if possible. He's ready and able, so we're gonna go with him. And ultimately, he does have agency. He's got the choice to make. But I would push for trying to get all three vaccines on board, particularly if we're already in October and you can see times running out. There's good data that states when you don't give the vaccine in your clinic and then the patient leaves, they're just less likely to be vaccinated overall, period. And this is one of those few things in primary care. I mentioned colorectal cancer screening, or maybe they're going to ophthalmology because they have type 2 diabetes. In this case, Brent does. As soon as they leave the clinic, unfortunately, the chance of them actually getting those interventions goes down. Vaccination is something I can control, where actually I get it, I place it, and I can check it off the list. They're done with with those three vaccines this year. So I would really try to recommend that he does do it. There is a slight increased risk of those systemic adverse events, but it's along the lines of like 4 to 8% giving multiple vaccines at once versus just the RSV vaccine. So it depends on his preferences, but yeah, I think that's worth it, and I'd rather just get the vaccines done with. And then there are patients as well who have a preference. Yeah, I just want to get it all over with. Like I'm not working tomorrow, so I'll be fine. I always emphasize to folks that if those systemic side effects are beyond the sore arm, that's usually gonna last, 1 or 2 days maximum, and you can take, acetaminophen, you can take NSAIDs, to alleviate some of those symptoms, and so I don't think it would interrupt his work at all if he wanted to go back. But those are just some of the tips that I would use and really try to get vaccines on board.
Yeah. Yeah, I love that the approach too, to use like it's gonna be a little sore anyway. You might feel a little crummy for a day anyway. Why do that twice? And that can
Right.
be a good, yeah.
And with the I mean, so I always try to put in context, it's really those systemic adverse events, myalgias and fatigue
Mhm.
that I'm concerned about because that's what patients expect the sore arm. But I mean, that's under 10% overall with the RSV
Mhm.
vaccines, correct? It's not a high
Correct.
rate like
Yeah,
25 or
correct. It
30%.
is, yeah. Yep, it is
So I mean,
quite
it's
low.
quite low. So yeah, and so I'll just tell a quick story
Mhm.
because I was in this situation because I've never had any systemic side effects from vaccines. So a couple years ago, I got my second herpes zoster vaccine. That's known, right? That one's notorious
Yes.
for causing systemic
Yeah.
side effects.
That's when I tell
I
patients
got
if
a COVID
yeah.
booster, and then that night I went to the gym, and I'm like, bring it. And I did actually for the first time, like, oh my gosh, it does feel like I'm getting the flu. Like it was really I was sore enough that like at night before bed, I took some naproxen and it really
Yeah.
felt like a virus coming on. And the next morning I woke up and just poof, gone.
It's
Like it
gone.
was,
Yeah.
yeah, it was really pretty amazing to like, is because it really felt like, this viral thing is, and I was kind of like, I had a full day the next day, but yeah. So, that's my N of one study that I
Yeah.
did where I'm like, I'm going to push it and see what happens.
Yeah.
Uh,
I
so,
like it. And
so I
yeah,
can
and I
tell that
usually
to
tell
patients.
patients, yeah,
Yeah, exactly. So we should
if
all
you
do
survive
that.
the
I'm
zoster
encouraging
vaccine, you won't notice this.
everybody out there should give this a shot. And then you can say, well, I've
Uh,
done it. And then, a little
yeah.
bit of pressure. All right. So let's talk about maybe that's your last step in communication. But we're going to talk about some better steps now and then telling your own personal stories. So the case we're going to set this one up is Lee. Lee is 72 years old, has bladder cancer, non-English speaking, coming in for routine monitoring adverse events related to immunotherapy. Has not received many ACIP recommended vaccinations. And you talk to the patient with a telephone interpreter. The patient is vaccine hesitant because the people with cancer should not receive vaccines. Ooh, this case rings so true, and it's so very common. Like, well, I have cancer, so I can't get a vaccine. I'm receiving chemotherapy. I have heart failure. I have severe lung disease. I have cirrhosis, and it's like, no, you're exactly the person. I know that you're a little more frail, but think of the infection. Whatever side effects could be related to something like the RSV vaccine, the infection is so much potentially worse for you on aggregate. So yeah, we really want to protect you more than anybody else. I really have done, and in primary care, I feel like I've convinced a lot of folks, 'cause I see so many individuals in a safety net clinic with multiple chronic illnesses, and of course your risk just multiplies for severe RSV the more significant risk factors you have. So I really kind of convince them now that they're getting the vaccines, and they're really trying to get them more proactively, which is outstanding. So I also see a lot of unfortunately a lot of lack of education for my patients, and especially with regards to RSV. They know what flu is, they know what COVID is. They don't know at all what RSV is. I have to introduce the subject all the time, and that does take a little time, but it's worth it. And then once we have that conversation, I will remind them. We'll keep talking about this. We will probably be giving you booster vaccines down the line, and a lot of patients aren't aware of this vaccine as well. It just was introduced at a time that's so challenging, where there's just a severe vaccine. If it's not outright resistance, like an active resistance, I have patients who do that, but more it's just a fatigue, and everybody's just tired of vaccines. And because I'm not familiar, and you've told me about all these other vaccines, then because that is the age range, right? These older adults who should be getting a good number of vaccinations. I get it, but it's to keep you healthy and prevent significant illness. So I'll just highlight a couple other barriers here. Costs. There's really good research that as your copays go up and the cost of any intervention, but especially vaccines, increases, the application goes down. So patients really can balk at it. So that's something that we want to try to control as much as possible. And I think also stocking the vaccines where it's available. The vaccine our vaccine fridge is getting busier and busier, and so we can't stock everything in our general clinic. So therefore, we can lean into pharmacy care as another way. Brenda, any comments on these potential barriers that you've noticed or that you want to call out specifically?
Yeah, I think another barrier related to education is even, as providers ourselves, as you were saying, Chuck, like we think about RSV as a baby
Yeah,
problem.
it's a
And I
baby
think
problem.
our understanding of the really serious impact on older adults isn't there. And so we need to educate ourselves to educate our patients.
Yeah, it's not a
Yeah.
baby problem. You can't just say
Yeah.
we're putting things in your mouth.
Yeah,
They can't
exactly.
help it.
As you get
What's wrong with
around
you, baby?
extremes of
Okay,
age. Yeah,
don't
extremes
eat
of
that.
age problem. Yep.
So pharmacies, it is amazing how they've really taken a much greater role in vaccine applications. So you can see that they're really now the site where most COVID-19 vaccines, most flu vaccines happen. So it's not out of our clinic. Pneumococcal vaccination happening there a lot as well. And RSV vaccination is also offered in pharmacies. I think the key here is communications, and patients who tell me, yeah, well, I'll just get it at the pharmacy. Many times I feel like that's kind of a passive out, that they're not actually going to become vaccinated. I know this just because I follow up with them, and it turns out they don't receive the vaccination at all. Also, it's really hard to communicate. We do have a vaccine registry in California, but I can't constantly go back to that registry during a busy clinic day and look things up, because patients just remember, I got 2 or 3 shots. I don't know what they were. And so oftentimes we actually do that kind of at the back end of the day, because there's still too much to do in a busy clinic. So what I'd like to see is greater partnership, better documentation, better communication, but absolutely community-based sites for vaccination that are convenient, that are open on weekends, that have some evening hours. That's really outstanding, and it makes a big difference. So our job is to both to educate and encourage. It's interesting when we think about that public health message, like, well, let's move into a recommendation that 60 with a significant chronic illness gets the vaccine, or 75 and above should absolutely get the vaccine. Um, that I would never cite the CDC or any other organization. I talk about how I would recommend it for my parents, and I would recommend it for my uncle because he has he has active cancer treatment, etc. And so start going forward and making a more personal choice. I think that's something that engages patients much more effectively and then can get you to goal, especially when you have a relationship with a patient over time that makes a big difference. So I think these are some of the key messages that you want to address. I generally like to say that that no matter what you're maybe concerned about, that a neighbor who got the RSV vaccine and their hand went numb for 2 days, and then they were really sleepy for another day. It's anything that's kind of an idiosyncratic reaction. Just return to the main facts that we're talking about hundreds of thousands of or over 100,000 hospitalizations among older adults, up to 10,000 deaths per year. And those are the things we're really trying to prevent. Brenda did a great job of highlighting those issues. So I just fall back on that baseline data and say, there can be a lot of different issues with vaccines, but generally speaking, they're there to protect you. Getting the disease is generally always worse than getting the vaccine, except for extraordinary cases. Um, yeah. And I think that you want to cast a wide net, try to, make sure your team is all involved, because if there's one person on your team who's saying, who's telling patients in the vitals room, I don't wouldn't, yeah, I know that it says vaccination on your list of issues today. I don't know about those vaccines. You may want to ask the doctor about that. And, that just is like crushes the whole enterprise. So you really all want to make sure you're on the same page. That's a good thing to huddle about in those summer and fall clinic days to make sure that you're promoting a vaccine and we're all singing the same tune. And then I just use a very iterative approach for vaccine hesitancy. Well, tell me more about that. Okay, can you explain that a little bit? And then I will, counter, because many times patients really don't have a strong idea as to why. I don't know. At the end of the day, it's just like, I don't know. It just seems like another vaccine. And, why is it so important? Well, it's important because, RSV can put you in the hospital, particularly when you have COPD or type 2 diabetes. All right. So there's a lot of ways to frame that conversation. And at the end, I really try to make it personal. And this is about you. I'm just concerned about you and your health. So the reason I went into medicine was to prevent disease. That's why I chose family medicine. And, we now have this tool. It's a shame if we couldn't use this tool to help prevent this serious infection known as RSV. And then make a decision with your patient. Hopefully, they get vaccinated. This is something that it's hard to do in one visit with a new patient because they don't necessarily know me. But that's why we have continuity of care. Maybe you can get them next time, and also maybe we can get them next year. I can't tell you how many patients who have been vaccine resistant in my practice who just said when I said, it's that time of year for vaccines. Would you be interested this year? Yeah, I guess I'll get one. I don't spend as much time talking to those patients about it because once I get the acknowledgement and the go ahead, I'm applying the vaccine right away. Because we are busy. I'm just being pragmatic. I don't really want to get too deep into it. I just am happy because I think once they get the vaccine, they realize that it's well tolerated. Their hand doesn't go numb, etc. Then I think they're going to be much more on board for future vaccines. And social determinants of health really do matter here as well. It's about kind of having a good knowledge of how vaccines work, having just the knowledge to balance the benefits and risks, because I tell my patients that everything I do, every single thing from your diagnosis to all our treatment decisions is kind of risk benefit analysis for me. But folks who have challenges in terms of low socioeconomic status, crowded living conditions, low educational attainment, all have special barriers to getting the vaccine, and understandably because of really some significant and highly tragic past activities where people really were discriminated against. There are some real reasons why they may be hesitant to get a vaccine. So I acknowledge a history of injustice. I speak to the fact that we are really trying to take that into account now during talks like this and during our practices every day. And that's why, again, then turn it back. That's why I'm focusing this on you, and this is why it's very most important for you to have this opportunity to get the vaccine, because it's going to keep you safe, and particularly if you come from a community like Lee's, because Lee being limited English proficiency, and having a history of cancer, he's already at risk a couple ways in terms of not getting vaccinated. So I'll turn it back to you, Brenda. How would you approach Lee's case?
Yeah, thank Lee for sharing his hesitancy, um, and the reason why, and really kind of flip that as to like, I'm so glad you brought that up. Like,
Right.
that is exactly the reason why, I, as your doctor who cares about you, want you to get this vaccine and why I'm recommending it for you. Um, and if he wants, you can go through the numbers, but often as he said, that real personal, that while there may be mistrust of systems or misinformation, in general, your patient trusts you as their provider. And if you come at it from I care about you and what's best for you, and that's actually the perfect reason why you should be getting this vaccine.
They've actually done research as to who is the most trusted source for patients in terms of vaccine information, and it's by far and away healthcare professionals. So it's not the crazy uncle or aunt. We all have those. And it's not social media or celebrities or influencers. It really is you, because you know the patient. So use that, leverage that knowledge, and make it personal. Like, I've gotten the vaccine. I would recommend this. If I was 60, because trust me, when I'm 60, I plan on getting the vaccine. And so I think that those are things that really can drive home the message. So just a brief summary. RSV infection is important, particularly among our older adults, certainly among children as well. And we've got different vaccination strategies that can protect infants. But it's really the older adults that unfortunately bear this tremendous burden of hospitalization and mortality related to RSV. And as Brenda very succinctly pointed out, that it also is going to make those chronic illnesses worse, which is the other thing that puts older folks in the hospital when they have an inflammatory condition like RSV. So we really want to take care of them. We want to recommend vaccination, especially if they're in a long-term care facility. We've got good evidence that RSV vaccination is highly effective at preventing symptomatic infection, but also severe disease, which is really, really important, keeping patients out of the hospital in the ICU. And yes, the more we can apply the vaccine, where rates are fairly low right now with under 50% uptake. We want to really keep rising that. And as we do so, public health will improve overall. So that is our time here today. Thank you so much to our audience for participating. And hopefully you found this information helpful to your practice. And Brenda, I just want to say thank you for giving us such wonderful information and being such a great resource for myself and for our audience.
Thank you, Chuck, and thanks everyone for listening and really informing yourself to help make the best decision with your patients to get the RSV vaccine.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Train Learning Network. This educational activity is supported by an independent medical education grant from GSK. To access all materials for this activity, visit peerview.com/DEN860.